Now we are recording. Well, we'd like to welcome everyone to tonight's webinar on anti-epileptic drugs. My name is Monica Anzalone, and I'm the program coordinator at the Epilepsy Foundation of Connecticut, where we are grateful for our partnerships tonight with SK Life Science, Hartford Healthcare, Ayer Neuroscience Center, as well as UCONN Health to deliver the presentation tonight. Medicine is the primary way in which seizures are controlled and is almost always the first form of therapy. There are different medicines to help with different kinds of epilepsy and seizures. Medicine controls seizures for about 7 out of 10 people living with epilepsy. Our presenters are going to give a very thorough overview on seizures in the brain and how medications work to treat seizures. They are going to cover the different types of anti-epileptic drugs, including some of the newer therapies that have recently been made available to patients. Just for everybody's information, all of you have been muted or should be muted throughout the program to maintain sound quality. This presentation is being recorded, so if you could just make sure that you're kept muted, and questions can be typed in the chat box at the bottom of your screen and will then be answered at the end of the presentation today. We are very grateful to SK Life Science for sponsoring tonight's program. SK Life Science Incorporated is the U.S. subsidiary of SK Biopharmaceuticals, which is an innovative global pharmaceutical company focused on the research, development, and treatment of central nervous system disorders. The company has a pipeline of 8 compounds in development for CNS disorders, including epilepsy. Meredith Heatley is SK Life Science Neuroscience Account Manager, and she is here with us tonight and has the honor of introducing our presenters.
Hello, good evening, everybody. Thank you so much for joining us tonight for this discussion. Thank you to the Epilepsy Foundation and Monica, and especially thank you to Dr. Martz and Dr. Greenfield for speaking for us tonight. I'm going to introduce, so you know that Monica mentioned that I work for SK Life Sciences. I'm the local neurology account manager for Xcopri. And I will be introducing Dr. Martz and Dr. Greenfield. So Dr. Martz is the medical director of the Epilepsy Center in the Ayer Neuroscience Institute in Hartford at Hartford Healthcare. Dr. Martz also serves on the EFCT Professional Advisory Board. Dr. Greenfield Jr. is the chair of the Department of Neurology at UCONN Health in Farmington, Connecticut, where he specializes in the care of patients with epilepsy. His research involves the cellular and molecular mechanisms of epilepsy and anti-epileptic drugs. He is board certified in neurology and clinical neurophysiology. Dr. Greenfield is also on the EFCT Professional Advisory Board. Thank you to both of them, and I look forward to hearing your talk.
Can you hear me okay?
Yes.
You head nodding, okay. I know everyone's muted, so they can't answer me. My portion, we have 2 portions of the talk today. I'm going to speak about, and I apologize for the technical issues, hopefully those are behind us now, but I'm going to speak about basically how, hopefully in a concise and clear way, how brain cells have seizures and how that leads to the brain and a person having seizures. And then I'll pass off to Dr. Greenfield, who will talk about specific medications that will be used to help that problem and stop seizures. Disclosures, I don't have any. I'm paid by Hartford Healthcare. So basically, we'll talk about what seizures and epilepsy are. It sounds simple maybe, but it's confusing to a lot of folks. A little bit touching on how networks work in the brain. Then we'll talk a little bit about how networks are made. That gets a little bit in depth. And then we'll talk about how the the networks can be dysregulated or made to work abnormally in the way that makes seizures or allows seizures to happen. So first, seizures and epilepsy as sort of defining them. A seizure, the main point about a seizure is that it's a transient episode. It's a single event that occurs in time. Of course, seizures may happen more than once in someone's life, obviously, but the definition of a seizure is that it's what happens in that moment. Whereas epilepsy is the condition of a predisposition to having seizures. And in addition, the other aspects that go along with that in terms of the psychosocial impacts that may also come with having seizures. So where epilepsy is a chronic condition, a seizure is an acute event occurring due to that condition. There are multiple types of seizures. This is a general breakdown from the very sort of highest level. You can have a non-epileptic category of seizures, which would include seizures that are caused by electrical abnormalities in the brain, but are not caused by epilepsy. For example, somebody with a very low sodium in their bloodstream, or someone who has taken a high dose of cocaine, or something else that could trigger the entire brain to flip into an abnormal pattern. And another category, which is completely different, is psychogenic seizures, which are not caused by a abnormal electrical firing of the brain, at least not that we can detect. And then an epileptic seizures, which is a different category essentially. And within epileptic seizures, there can be focal or generalized epileptic seizures. In terms of the kind of seizures, in terms of a generalized seizure, if you picture your brain being an orchestra, the idea with generalized seizures is that they're, generally speaking, doing any one part of the brain is doing what it's intended to do. It's just that it's been given the wrong commands. And if any of you are old enough to be, at least in my generation, you remember the cartoon, which is not coming up right now. Slide should just quit. Apologize. Let me try to get back there. Trying to resume from here, but I'm not sure if it's going to do that. Okay, we'll see if this works. So the entire brain working as it's being instructed to, but with the wrong instructor. So if you remember the cartoon where Bugs Bunny takes over the orchestra and all mayhem ensues, the reference being that the conductor, in this case, can conduct the entire orchestra to do the wrong thing, even though each individual member of the orchestra may be following their commands correctly. Which is very different than a focal seizure, where again, same orchestra, but in this case, you've got one particular part that is functioning differently. I don't mean to imply that a punk rocker is necessarily bad, it's just different in this case. And so you might have that one portion of the orchestra playing its own tune. And that can do lots of different things. It can disrupt the people that are nearby, so they're still trying to play the orchestra as intended to play the symphony, but they're a little distracted, and so they're not playing quite as well as they normally would. In addition, you might have other members of the orchestra who actually know the songs when they're not playing in an orchestra. Maybe they're also punk rockers, so maybe they start playing along with the punk rock song, and that leads to real disruption of the symphony at that point. And in some cases, the entire symphony orchestra might start playing the wrong song, which would be more or less a model of a focal seizure starting in one particular area and then spreading to nearby areas, causing dysfunction and eventually maybe to the whole brain. So now that we've defined the basic differences between seizures and epilepsy, and more particularly focal seizures and generalized seizures, we'll talk a little bit about brain networks. The brain is a connected area of, or all areas in the brain are connected through white matter tracts, and as well as local connections from gray to gray. So in a generalized seizure, you've got deep areas of the brain you can think of almost like the conductor that are highly connected to the rest of the brain. So if one of these areas, which are also connected to each other, starts having dysfunction, it very quickly spreads to the rest of the brain. I think maybe Monica, I think maybe your mouse is bumped or something like that. Every time that happens, I think I lose control of the screen.
What's that?
I just saw the mouse move, even though I didn't move it. So I think every time you move the mouse accidentally, perhaps, it's taking a control away from me, and then the slideshow closes.
Okay.
Okay, let's try that again. So you can have it quickly spread to all parts of the brain from that one area. So just by having one cluster of neurons or set of structures in the brain be abnormal, you can have a seizure that affects the whole brain very quickly, and that's how generalized seizures we think work. Whereas a focal seizure might be somewhere more towards the cortex or the outer rim of the brain and cause dysfunction in that one area. And if you have spread from that one area just to nearby structures, you might have what's called a focal retained awareness seizure, where there's some symptom being caused by whatever part of the brain is affected by the seizure. Could be a movement of an arm, or it could be an emotion, could be a deja vu feeling, but you're still aware, and only a small part of the brain is affected in that moment by that seizure. But then that seizure may spread further to other areas of the brain, enough that it does start to impact someone's ability to respond to their surroundings or talk. And that would be called a focal impaired awareness seizure. Again, starting focally, but spreading a little more. And these focal seizures have the potential to spread to most of the brain. And if they do that, again, through normal pathways of spread, then they can cause a full-blown seizure like you might imagine, where people fall to the ground and shake, a generalized tonic-clonic seizure. So how do these networks form, and what is their purpose? So we'll start by talking a little bit about neurons, and we'll move into networks. So this is a schematic, a little cartoon almost of a neuron, just to give you something to work with. We're going to use this throughout a lot of the rest of the talk as a reference. I just want to make sure we understand the parts here. So that middle triangle where it says cell body is a representation of the body of the cell that does all the internal regulation features of the cell, maintaining its energy and its cellular integrity and its cell membrane around it. That's where the sort of the cell's life is maintained, as you say. To the left of that, where it says input are dendrites, the physical structure are dendrites, and that's where the input comes to this neuron, to this brain cell, to tell it when to do its job and how to do its job. Then the output, you see all the electrical sort of lightning indicating that that's where the electrical current would go down out of the cell body, down to the axon, through the axon to the end of the axon where there's actually a synapse. And so the neuron in sort of its crudest form and certain, the kind of neurons we're referring to mostly here, consists of those basic three parts: the input through the dendrites, the cell body that maintains the life of the cell, and then the axon where it sends its output. Interestingly, we often think of the axon as being the major part, and it is important because that's where the cell tells the next cell in line what to do. It gives input to the next cell. But actually, if you look at a lot of types of neurons, the input section is much bigger. See in this image that the cell body and the dendrites take up much more space physically than the axon, which is very thin at the bottom there. That just gives you a sense that the life of the neuron is all about when to fire. When should I send my signal? Because it's extremely important that it does so only when it's supposed to, never when it's not supposed to. But it has to be very reliable that when it's supposed to, it does. So you can think of it as having a very itchy trigger finger that is extremely highly attuned to the right situation. These inputs from the dendrites, other neurons connecting to it through their axons, are what help it to do that, to live right at the edge of being able to fire, and then it knows exactly when to do so with the slightest nudge. Generally speaking, there's other neurons would talk to any given neuron and give it either excitatory or inhibitory inputs. Excitatory meaning, yes, you should fire, go for it, whereas an inhibitory might tell it not to. Hold on, take a chill pill. And so the way neurons generally are built is that the excitatory inputs tend to happen further back at the top of this picture. And then in the middle there, you get more of an inhibitory inputs, and then right by the cell body. And that means that as much excitement as might come in, or as much stimulation to go ahead and fire might come in from the top level dendrites, there's still a braking mechanism towards the body of the neuron where the inhibitory inputs can say, nope, hold on. You get this nice balance that keeps the neuron kind of at the point where it can fire, but only really does fire when all the right inputs come and it's really supposed to fire and give a signal to the next neuron. So this is a schematic of what we just talked about. The middle neuron there talking to the next neuron, and coming into every neuron really are a mixture of excitatory and inhibitory inputs, the balance of which makes all the difference. I'm not sure how clearly these are coming through. On my slides, they're coming through okay. So you can read through. There's also another factor is the extracellular space, which is just the environment inside the brain in which the neurons live. That'll become important a little bit later. So how neurons talk, this is a pretty complicated drawing, I realize. I'm going to walk through it a bit. But at the top, you see the neuron. That's the neuron we just talked about. And it has its axon, which sends its action potential, a little lightning down. And it does that by, the way it connects to the next neuron is through a synapse, which is a space that sort of where the end of one neuron connects to the dendrite of the next neuron. The synapse in and of itself, even though it's a very small space, is an extremely important and highly regulated part of the brain. What happens when the action potential fires down the axon is that at the end of that, into the synapse are released neurotransmitters, and you've probably heard of many such neurotransmitters before. The most commonly talked about ones in the brain are glutamate, which leads to excitement of the next neuron in line, or GABA, which leads to inhibition. Those cross the synapse and go along to receptors, which are sort of antennae that stick out of the body of the neuron or the dendrite of the neuron. They receive those inputs, they take that signal, and then they pass it along as either an excitatory or an inhibitory message. That goes along to the next neuron, and so on and so forth. You can have multiple neurons connecting to any one neuron, and it's the balance of those that makes the difference. And the gracious amount of electrolytes, sodium and other charged molecules that's surrounding these cells also makes a difference into how quickly, when they will fire. The cell membrane is a really important part of the neuron, the body of the neuron, and the entire neuron, because it's what keeps, just like our skin, really, it keeps what's in us in and what's out. So the neuron is defined by the cell membrane, right? That's what its border is. And it's always interacting just like we are with its environment, the cell, the extracellular space that's around it, and the chemicals that are released into that space. And so there's a lot of molecules that go up to making the cell membrane. And this is just to give you a sense of that there's very complicated pieces in there. Each of these molecules can be made up of typically of small proteins, but there's genes that go into making these. So there's many genes that go into making many proteins. Many of these individual molecules are made of multiple types of proteins or multiple genes. And so any little patch of cell membrane is extremely complicated in terms of not only how it was sort of created by the cell through its gene expression, but also how it's maintained and kept healthy. And what it does is it very carefully regulates what can come in and what can come out of the cell, because that difference is what makes neurons excited or not. So these receptors and everything else we've been talking about ultimately has to do with what amount of what amount of electrolytes and charged molecules it lets into the cell versus letting out of the cell, which creates the balance that really creates the electrical thresholds for when to fire or not to fire its action potential signals to the cell. So this is again a schematic, and I realize we're getting a little complicated here, but I'll walk you through this. Essentially, if you look at the bottom part, that's meant to indicate one area that's separated, like for example, by a cell membrane, like the inside of the cell from the outside of the cell. This is just meant to show you that by using the cell membrane, that dotted hashed line that goes across the middle of this square or rectangle, you can basically regulate what can go across. You can regulate by only letting certain types of charge, only positive things come across, or only negative things come across. Or you can do it by the type of size of molecule that it is. Big molecules can't get through, but small ones can. And this has to do with how big of a tunnel or a pore you're opening through the cell membrane, at which time, and for how long, and where in the cell membrane. And so by carefully regulating all of these factors, you create a controlled environment where you can have more or less positive charge or more or less negative charge. You can do that by the chemical itself, like by sodium as opposed to potassium. If you have more and more sodium, you'll have more of a positive charge. So all these factors go together to create the electrical potential of the cell membrane or of the cell body. And so when that electrical potential hits a certain amount, then it triggers the action potential to happen. And so really what the neuron is actually doing by using all these complicated proteins and regulating its cell membrane so carefully and balancing all these inputs that help to impact the inside and outside concentrations of the cell, really doing is setting itself up to be ready to suddenly open up channels and let ions flow through its membrane. That's what triggers it. But you can do that by just sort of walking through various ways. There's a graphic here that hopefully is showing, and it's just to give you an example of what it might look like when an ion channel is opening or closing in a cell membrane. On the left, you can see how this protein structure might be situated or located inside the cell membrane, with one end on either side, on the inside and the outside. By changing its shape, it can have a bigger or a smaller hole or tunnel through the membrane. And so it has what's called an open and a closed state. And when it's tightly closed like that, ions cannot pass through it. When it is has a bigger opening, then ions can pass through it. And as soon as they can pass through it, they will pass through it, as fast as they can, essentially. And what triggers the opening or the closing can be a variety of things. The main categories we talk about are voltage gated or ligand gated. Voltage gated means that when the electrical potential of the cell hits a certain threshold, it causes this actual protein to change its shape. Just that, just the electrical potential of the cell dictates whether this is in an open or closed state. Whereas a ligand gated channel is one where a receptor comes along, like GABA or some other type of molecule, and hits the specific receptor that's located on this channel and is part of this channel. And when the receptor is activated by that molecule, then it opens the channel. When that molecule is not there, the channel closes. And that's the way that many neurotransmitters help to impact downstream neurons. They come out of the synapse, they go down the ion channels, they cause them to open and close. And the opening of pores or channels allows whatever is in the outside of the cell to flow in, or whatever is on the inside of the cell to flow out. That affects the threshold. Ability to fire the action potential. This is a link that I don't know if I think this might be a little too hard to get working here for this, but I would highly recommend you go to this link. You can easily find it by searching for Lilac Chaser, and it's a nice sort of exhibit online of how brains work. If you do it, what it'll show you if you follow the instructions on there is it shows you how your brain is constantly tuning these channels. If anyone's doing it online now, I'll just talk through it briefly. Basically, it's a series of circles around a plus sign. If you stare at the plus sign and don't move your eyes, what happens is the series of circles around the edge, your brain decides that those are not so important. You're staring at the plus, that must be what you care about. And so your brain is really completely tuning out the circles that are around the edge. And if you stare at them long enough, they will literally disappear. This is demonstrated by a negative image, because when you're seeing a sort of purplish pink that it shows you, when that stimulus is gone, your brain is adjusted to sort of tune out the purple. What you get left with is a negative image, the opposite of purpley pink, which turns out to be kind of green. What it looks like is there's a green circle going around in a going around, and eventually all you see is that green circle, and that's because your brain is completely tuned out to purple. So this is really, it's kind of complicated to describe. It's easy to do if you follow that website, but the point is that your brain is tuning what it cares about by adjusting when those neurons should fire. So in addition to being carefully regulated at all times when the neuron should fire, your brain can also adjust the set point for when those should fire. So we've talked a little bit about networks there. I think there are some slides that we're missing somehow. So in terms of how seizures happen, how the brain networks and cells get dysregulated in a way that allows seizures. Well, we just went through very quickly a lot of pretty complicated stuff, and any error in any of those things really can cause dysregulation that allows seizures. So we'll walk through some of those more specifically. The bottom line, or the main point here, is that this is a concept that's a little outdated now, but still works pretty well for understanding the general idea, which is that if a neuron is hyperexcitable, then it can cause abnormal firing when it's not supposed to, and that can trigger seizure. So either you have too much excitation of a neuron, or else reduced inhibition. If it's supposed to be inhibited, but there's nothing inhibiting it, then it can fire more. And then also you can have times that it's getting the right amount of excitation and inhibition, but it doesn't respond normally to those things. Maybe it has too itchy of a trigger finger, that particular neuron or set of neurons or cluster of neurons. So whenever you tip the scales towards excitability, you're at risk for having abnormal firing, and in the case of epilepsy, that can cause seizures. Going back a little bit to that complicated drawing that we looked at, just to reference that you can have any number of abnormalities on there that can cause epilepsy to occur. So you might, and what matters is which ones they are. So if you have, let's say, a particular gene that's abnormal, and it happens to code for a particular membrane protein. We talked about how important it is whether to be open or closed to allow molecules in or out of the cell itself. Well, if that's open too much and it's allowing too much flow, it's going to throw off the regulation of the cell. So the gene, one single gene or one single ion channel can in fact cause epilepsy, particularly if it's widespread, meaning that it's in not just one single neuron somewhere in the brain, but that gene is being used by lots of neurons throughout the brain. You have lots of neurons that are dysregulated in that way. That's one way that you might have genetic epilepsy. You can have, receptor genes that are abnormal, that are when the GABA or the other molecule for that receptor comes along, that it impacts the channel to open for too long. It's supposed to open for a second, but it opens for 5 seconds, and that allows too many molecules to pass through. So there's any number of ways that you can end up where a neuron is dysregulated. We're going to talk about a few of those a little more in detail, just using the schematic drawing again. So a provoked seizure, remember, we talked about is not epileptic. That's one that's caused by something else affecting a normal set of brain. So for example, all the brain might be affected. So a common example of that might be alcohol withdrawal. Someone who's a steady drinker and is used to having a lot of alcohol in their brain, so that their brain has learned that that's normal and adjusted everything to be used to alcohol. But now when you suddenly don't have alcohol, that causes a sort of system-wide problem for the brain, and that can cause all the neurons to be dysregulated. You can have a genetic, or what we call generalized epilepsy, where people have generalized onset seizures like we talked about, and that can be due to a number of different neurons throughout the brain having an abnormal balance of an ion channel or some other disrupting the ability of the cell to maintain its own set point right at the threshold for causing seizures. And again, that can be a certain set of cells in the deep structures of the brain that can trigger the rest of the otherwise normal brain to fire when it's not supposed to and cause one widespread seizure. Or it could be that that gene is really affecting most neurons in the brain, in which case the brain would be very abnormal. You can have abnormal networks where, as we talked about, you have not enough inhibition. So if you're supposed to have a nice balance between the positive and the negative here to keep the neuron in the middle right at the set point, but instead you have just a tiny little inhibitory input. Now what would normally be a normal amount of excitation is throwing the scales way off, and you have too much excitation, therefore hyperexcitability. Same could be true with more excitation. For some reason, the inputs to that neuron are creating it to be hyperexcited. Even though the neuron is doing its job, it's trying to respond to the inputs it's given, but it's been given either too little inhibition or too much excitation. And so seizure medications are aimed at trying to stop a variety of these problems, typically trying to balance the neuron again, get it back into the set point that it's supposed to be at, get rid of the extra excitation that it's trying to deal with. That can be done in a variety of ways. You can have neurons themselves be calmed, where you affect the ion channel so that it can't let as much flow through as it normally would. So even when it is hyperexcited, it has less of a response. You can, of course, that may also cause problems in the non-epileptic part of the brain. The neurons that are meant to be functioning normally, that do other functions like language or thinking or walking or whatever, may also be affected like this. So if all neurons across the brain are inhibited, extra inhibited, then you might feel cognitively slow or tired, or that your balance is off because your balance networks are also inhibited. So that's where we have to balance getting the right treatments in one part of the brain that's causing epilepsy without affecting too much of the brain. This is just a little graphic to show a couple of the common seizure medications. Some of you might be familiar with some of these names. We're using the generic names here. But the topiramate has some activity both at sodium channels on the cell membrane, but also has some impact on the GABA receptors. Synapse, where the neurotransmitters are released when the action potential comes along. Levetiracetam, which goes by the brand name Keppra. That medication reduces the amount of neurotransmitter that's released into the synapse, therefore reducing excitation at the downstream next neuron involved. Down below, I've listed another bunch of medications that act at different types of channels in the cell membrane or different types of receptors, effect channels. These are things that help to increase the inhibition of the cell itself so that it's less prone to firing when it's not supposed to. This is something I think I don't want to take too much away if Dr. Greenfield's going to go into these things, but essentially, why is it when you take seizure medicines that they don't always work? That's the general question. Sometimes you just have so many abnormal cells that you can't control all of them without getting side effects. Sometimes you have either a lot of cells or even just a few cells that are so abnormal, they're so dysregulated that the seizure medications, even though they're tipping the scales back towards balance, can't tip them enough. The seizure medicines just can't quite create enough inhibition or reduce excitation. You might have the case that the side effect of the seizure medicine could work, but it comes at the cost of too many side effects. And that's obviously not a good way to live, and therefore it doesn't allow the seizures to be fully controlled. In some cases, there's actually medication resistance. There may be other parts of the cell that are actually fighting the seizure drug itself. Sometimes they kind of spit it back out and don't let the cell be affected by that drug. Sometimes the cell has receptors that are responsive to that particular drug, and for reasons we don't fully understand, it removes those receptors from its cell surface so that the drug can no longer affect the cell. There's any number of ways, just like there's so many ways that the cells can be affected to cause seizures, there's a number of ways as well that the cells can be resistant to medication. So that's the end of my portion. I don't know if you want to take questions now or do that at the end.
Um,
The time
we can go ahead and take questions for this portion of the presentation. If anybody, the only thing is that you have access to the chat room, Dr. Martz.
I will fix that.
Okay.
And maybe you can relay questions. Why don't we maybe do like 1 or 2 questions, and then we'll let Dr. Greenfield do his talk, and then those folks who want to stay on till the end
Okay.
have additional questions, and I'll hang around for that.
Okay. So do I have control again?
I believe so.
All right. Okay. So yeah, if people want to type any questions in the chat box, you can feel free to do that now. If not, you can hold on to the questions towards the end. We can answer them then.
I do see there are 5 chat comments there. I'm not sure.
Okay. All right. Well, I'm going to go ahead and hand this over to Dr. Greenfield. Or Dr. Greenfield, I think you can request control on your end.
Try that.
Like you did before.
Okay, click mouse keyboard. Okay, let's see where we are.
There you go.
Show from current slide. Why didn't that work? Start. Okay. Okay, so here we go. Can everybody hear me? Does that sound reasonable?
Yes.
Yes.
Okay. So my portion of the talk is going to build on what Dr. Martz was talking about. And so we're going to do kind of a whirlwind tour of the so-called anti-epileptic drugs. And the first thing I have to tell you, besides that I don't have any conflicts, is that we don't have any anti-epileptic drugs. I'm sorry to disappoint everybody, because anti-epileptic would imply that something that these drugs do affect the underlying epilepsy, and our drugs don't do that. In fact, what our drugs do is they treat the symptom of seizures. They're really anti-seizure drugs. So they decrease the frequency or the severity of seizures and treat the symptoms of seizure recurrence to try to prevent them, but they don't alter the natural history of epilepsy. So given that, our goal is to try to improve the quality of life by maximizing our control of seizures while minimizing the number of side effects that we have. And since they don't affect the underlying epilepsy, all we really care about is how well do they work, and let's try to make sure we don't create too many side effects that we don't want. So I wanted to show you this lovely example of sort of an early therapy for epilepsy. So you can see that this is a skull and that there's a nice hole in there, a window in the skull. And then there's this lovely surgical instrument on the left-hand side. And this is an Inca operation that was done to treat epilepsy. And it was a very mechanistic approach to epilepsy because they knew, of course, that seizures are caused by demons in your brain. And all you have to do to treat the epilepsy is allow the demon to escape, and then people will be better. And so even in early times, the people took a very rational approach, and according to their understanding of how epilepsy worked, they devised a treatment that they thought was going to work. I don't know how well this patient did, but obviously you can see some healing on the sides of the bone there, so it suggests the patient at least survived the operation. So we have lots of medicines. This is a graph of the occurrence of medicines over time since the 1850s, when we had bromides, which made people go to sleep, and the introduction of phenobarbital in 1912. And then since then, we've had a sort of dramatic increase in the number of medicines. We have almost 30 medicines available now. So the question is, how do we make sense of these? Well, you can divide these up into different categories. So this is the first generation up through about the early 70s, including medicines we still use like carbamazepine and Depakote, Valproic acid. And then the second generation started in the 90s with felbamate, which did not do so well. but through the late 90s. And then the third generation started with levetiracetam, a very commonly used drug, and up through a variety of different drugs for different reasons. So there'll be a quiz at the end. I'll expect you to have memorized this slide. Actually, there won't. Okay, so how do we make sense of the anti-seizure medicine? There are two principles, and when I teach this to medical students and residents, the things that are easiest way to sort of plug in and remember about the drugs is that the kind of seizures that are helped by the drug depend on the target of the drug in the brain, and that's usually a molecule on the cell, and what the brain does at that target. And at the same time, a lot of the side effects of the drugs depend on that target and what it does at that target. So we're going to spend a little bit of time talking about what those targets are, and that will help you sort of lump a whole bunch of seizure medicines into a category and help you understand how they work. So the first category is drugs that work at a protein in the cell membrane called the sodium channel. The sodium channels open up and allow action potentials to flow down the axon and signal the next cell. So they're really essential signaling molecules. And this is a cartoon of one in the brain membrane. And when they open up, sodium rushes into the cell, it depolarizes the cell, and the action potential shoots down to the synapse where it signals the next cell. Sodium channels are really necessary for firing of the cells and for communicating, but sometimes they're too active. And so one way to put the brakes on, as Dr. Martz was saying, is to slow down the way that these sodium channels work. So in a control neuron, you have a depolarizing signal and a bunch of action potentials riding on top of it. If you bind an anticonvulsant to the channel, the ones that act at the sodium channel, it prevents that. It sort of stabilizes an inactive state of the channel. And so only a few of these action potentials get through, and that allows the brain to still communicate, because you can't go through life without your cells being able to talk to each other. But it prevents all these extra signal action potentials from happening, and that helps prevent the extra excitation that can cause seizures. So sodium channel drugs help prevent focal seizures by preventing the spread from a focus of seizure onset. So these are mostly drugs that are good for focal onset seizures. And because poisoning sodium channels, which is what we're doing, affects other things that the brain does, they have very predictable side effects. So they can cause double vision and jerky eye movements called nystagmus. They can cause coordination problems and dizziness. And then at even higher levels, it can cause some sleepiness and fuzzy thinking. And all of those side effects are dose dependent and they're reversible. So all you have to really do in that setting is reduce the dose of the medicine and try to get a better balance between the anti-seizure effect and the side effects of the drug. So we have a variety of our favorite drugs that we use a lot that use sodium channel as a mechanism. Those include phenytoin, which is Dilantin, carbamazepine, which is Tegretol, valproic acid, which is Depakote, Lamotrigine, which is Lamictal, topiramate, which is Topamax, and then there's some newer ones here that I'll go over as well. I'm not going to list them, you can read them. Some of these have multiple targets. I think Dr. Martz mentioned that topiramate works at inhibitory sites as well, the GABA-A receptor, which we'll talk about in a few minutes, and so does phenobarbital. So some of these drugs are what we call dirty. They have multiple mechanisms, and dirty is not necessarily bad. It just means that they have multiple ways of working. Okay, so let's talk a little about phenytoin. This is a picture of the drug, what it looks like in its structure. It works on sodium channels, and it's useful for mostly for focal, but also generalized, what we call what is commonly known as grand mal seizure, generalized tonic-clonic seizures, typically dosed at 200 to 400 milligrams a day, and it's broken down in the liver, so it tends to interact with some of the other drugs that people may be on. Allergic reactions can develop to almost any medicine. It's not unusual to have a rash, and that would mean you would not want to take the drug any further. And because it's a sodium channel drug, it has predictable side effects such as double vision, dizziness, sleepiness, coordination problems, all the things I just told you about as sodium channel drugs. But it also has some specific drug effects, like this gum overgrowth that happens particularly in people who are not able to take good care of their teeth. It's an overgrowth reaction of the gums, sometimes requires surgery to fix. And thinning of the bones, osteopenia, which can predispose you to fractures. So we tend to counteract that by giving extra vitamin D to improve bone density. One of the next favorite drugs that we use is carbamazepine, also a sodium channel drug, also used for focal seizures. The dosing tends to be a little bit more varied and require 3 times a day dosing, because at least in the regular formulation where it's immediately released, it gets out of your system fast enough that you have to give it 3 times a day. But there are some preparations that are longer lasting, where they have a slower release process so that you can take it only twice a day or even once a day. Same kind of dose-dependent side effects and a couple of drug-specific ones. It can cause problems with creating new blood cells called aplastic anemia, which is a bad condition. That's fortunately very rare these days. It also can produce a rash, and in Asians, people of Asian extraction, there's a specific genetic marker that seems to predict who's going to get the rash. So typically these days, before we'll start carbamazepine or one of its derivative drugs that I'll tell you about in a minute, we will, in people of Asian ancestry, we will check this marker to see if they are at higher risk of developing a rash. The other thing that it can do is low sodium, and it turns out low sodium is one of those things that can trigger seizures, so we don't want that to happen. So we typically will monitor for that. There are a couple of second and even third generation drugs derived from carbamazepine. There is Oxcarbazepine, which, if you go back up and remember this structure right here, it looks just like it, except we added this little O here, and that's an ox. And so this is Oxcarbazepine. So Oxcarbazepine was made that derivative. They made that derivative because one of the byproducts, as it's broken down, creates some side effects, some symptoms. It makes it more likely that people are going to have some of those toxic sodium channel effects that we talked about. And so by putting this little group on there, it makes it more tolerable because that metabolic pathway is no longer available. So you can dose it a little bit higher. You can see 300 to 1200 milligrams and only twice a day. It doesn't induce the liver to break itself down the way that carbamazepine does. But it does cause the low sodium, which carbamazepine does, probably even more so. And so we tend to follow the sodium levels with Oxcarbazepine. And then there's a third generation drug called Carbamazepine, and that has to do with the fact that some of these structures have these funny handedness to them, left-handed, right-handed, and it's how these drugs stick out or into the plane that you're looking at. And so this formulation is all S, so that's where Esli comes from. Carbazepine is all S-oxcarbazepine, and so when this gets into the blood, this group gets clipped off here, and for all the world, it looks like just one of the handed versions of oxcarbazepine in the brain. It's broken down a bit more slowly, so you only have to dose it once a day. Has the same kind of side effect profile. So let's go on to the next one called valproic acid or Depakote. This is a very commonly used drug, also a sodium channel drug. But as I mentioned, some drugs are dirty, and this one has a side effect where it also blocks what we call T-type, short-acting, low threshold calcium currents that we find in the thalamus. And that's one of the main mechanisms for creating a special kind of seizure called absence seizures, where it's just bland staring and then recovery. These are common seizures in kids. And it may also have some effects on GABA inhibition, but those are a little, probably not the major mechanism of action. We use it for focal as well as generalized and onset seizures. And it's also, as I mentioned, useful for absence seizures. It is a wonderful drug, very effective for juvenile myoclonic epilepsy, which is a type of epilepsy with generalized jerking as well as little jerks that happen often in the morning. This is a syndrome that is relatively common among the generalized epilepsies and very hard to treat unless you have the right drugs, and valproic acid is one of the right drugs that works for it. It's also used, a lot of our drugs get picked up by the psychiatrist because they find that they're useful for other things. So it's used in bipolar disorder and mood stabilization, and it helps keep headaches away. So it has a variety of things it can be useful for. It's broken down in the liver, and it affects the drug metabolism of a variety of other drugs, particularly if you're on the anticonvulsant Lamotrigine. It slows down the breakdown of that. So if patients are on both, you have to really lower the dose of Lamotrigine to ensure that that doesn't cause the typical sodium channel side effects. It has some adverse effects. It can cause you to gain weight. So there's this mnemonic for remembering that: fat, shaky, bald, and yellow. Fortunately, most of those things don't happen very often. It does make you gain weight. You have to watch what you eat. It can cause a mild tremor, which is usually just a worsening of the tremor as if you drank too many cups of coffee. Can cause a little bit of hair loss, and that's usually just a few extra hairs that you find in your comb. It's not permanent, but if it's troublesome, sometimes we will cut the dose or change to a different medicine. And rarely it causes some worse liver problems, causing jaundice, which is where the yellow comes from. So it's something we pay attention to. That fortunately does not happen very often. It also is kind of notorious for causing birth defects, and particularly defects in the formation of the neural tube, which is what makes the brain. And so a side effect of that is spina bifida. This can partially be reduced by giving folic acid, a vitamin that we give to most women of childbearing age. It can also cause some cognitive problems in children born to moms who are taking this. So it is not our favorite drug for young women who might want to get pregnant. It has a lot of good sides to it, but also some side effects that we are concerned about. Lamotrigine, I was just talking about, another sodium channel drug useful for focal and generalized tonic-clonic seizures. It also is broken down in the liver, which is where it interacts with the Depakote. Side effects are the usual suspects that I mentioned before: double vision, coordination problems, and it can cause a rash. It seemed to cause this a whole lot when we first started using it back in the 90s, but I think that it was due to the fact that we were escalating that dose way too fast before we knew better, and now that we take a very slow escalation of the drug as we get people used to it, we see this much less often. Topiramate is one that Dr. Martz mentioned, also a sodium channel drug, but again, like some of these others, it can enhance inhibitory neurotransmission, the brakes that signal a neuron not to fire so much. And it has another effect on an enzyme called carbamic anhydrase. This is the same enzyme that's in your tongue that makes the fizziness in soda taste slightly acid and gives it the fizzy taste. So it prevents that, and as a result, soda tastes flat. That's one of the side effects of this drug. Useful for focal and generalized tonic-clonic seizures. Also pretty good for absence seizures, for myoclonic seizures. It can help prevent migraine headaches. We use it a lot for that at low dose. It takes actually a much lower dose to prevent headaches than it does to prevent seizures. Has the same sodium channel side effects, but has a few other things because of this carbonic anhydrase inhibition. and that's due to this sulfonamide group here. It can cause tingling at the fingertips and at the lips and at the toes, and it tends to cause some confusion if you escalate the dose too quickly. One of my colleagues nicknamed it Dopamax because back when we were first studying it and also escalating the dose faster than you probably should, a lot of the patients were reporting foggy thinking. These days, as long as you escalate it slowly, it seems to be much better. The other risk, again, because of this sulfonamide, is kidney stones. One of the plus sides of this medicine is it tends to make people lose weight rather than gain weight. So people who have just been on Depakote are really happy to start this medicine. Okay, so I mentioned before that there are different mechanisms, and the second mechanism I wanted to talk about that a lot of these drugs use is inhibiting excessive excitatory neurotransmission. And the way that they do that, besides working at the sodium channel, is at some targets right at the synapse itself. So there are calcium channels that are necessary for the neurotransmitter glutamate to be secreted across the synapse and interact with the postsynaptic receptors. And several of these medicines, gabapentin and pregabalin, bind to a subunit of that calcium channel and seem to put the brakes on it. They don't completely shut it down, but they prevent excess excitation. So that's a site for one. A second mechanism is that on these vesicles itself that contain the neurotransmitter, there is a binding protein called synaptic vesicle protein 2A. Remember, this will be on the quiz. SV2A is the binding site for medicines like levetiracetam, which everybody knows as Keppra, and brivaracetam, which everybody knows as brivaracetam or Briviact. This is a new one, so the reason you don't know that is that it's pretty new. So these drugs bind to this, and again, by magic that we don't completely understand, they prevent excessive release of glutamate, and that slows down the excitatory neurotransmission. Then there's a third mechanism. Yep, let's go back. My arrow seems to have disappeared. So perampanel, it's really hard to read. Okay, so perampanel blocks these receptors, these AMPA-type glutamate receptors, and so it blocks on the postsynaptic side the glutamate from binding and signaling to the postsynaptic receptor. And that's, again, a fairly newer type of anticonvulsant mechanism, but all of these are ways of putting the brakes on excessive excitation. So gabapentin is one of those drugs that interacts with the calcium channel. It's also useful for focal seizures. We use it a lot for headache control and neuropathic pain. It is used at a wide variety of doses from 100 milligrams to 1,200 milligrams 3 times a day. Side effects are generally pretty mild. It's a well-tolerated medicine. It can make some people sleepy, can cause some coordination problems, can cause weight gain. Some people will notice some swelling at the ankles. But again, very well tolerated, and sometimes we use this in the elderly because it works pretty well. Pregabalin is very similar. Both of these were designed to look like GABA. It may or may not look like that to you, but that's how they were thought to be designed or derived from. But they don't work on GABA inhibition. They work on excitation at the binding to that calcium channel. This drug is a lot more potent. It binds to the same site. And so it is also useful for headache prevention and for pain control. So levetiracetam these days is one of our favorite, most commonly used drugs for a variety of reasons. It tends to be very well tolerated. It is the one that binds to the SV2A synaptic vesicle protein, and again, seems to prevent excessive neurotransmitter release. Side effects, again, are mild in most people, a little sleepiness or coordination problems or a sense of weakness. In about 10% of people, it can cause some personality change. People just get irritable and angry, and usually it's not the patient, it's the family that wants us to take the patient off this medicine. Say, I can't stand him, take him off. So that happens. Fortunately, we have this newer version called brivaracetam that works at the same site, but it binds 20-fold tighter. So that makes it much more potent. We use much smaller amounts of the drug, and it's better tolerated and less likely to cause the personality changes than levetiracetam is. So then the third mechanism is to enhance inhibition. So this is now an inhibitory synapse. There are a few drugs that work on the either the breakdown of this inhibitory neurotransmitter, gamma-aminobutyric acid. That's what GABA stands for. Gabapentin blocks its breakdown in the enzyme that does that, and tiagabin blocks its reuptake into terminals. We don't use either one of those very much because they are associated with a lot of side effects. The ones we do use a lot of are the ones that work on the GABA receptor itself. The barbiturates that enhance GABA receptor function, and so do the benzodiazepines, but they do it in slightly different ways. And what those drugs do when they bind to the GABA receptor is they allow chloride, a negatively charged ion, to enter into the neuron. Negative means hyperpolarized. It tends to make the cell less responsive, and that quiets things down. So the benzodiazepines that we typically use for seizures, there are a couple of them. Clonazepam or Klonopin is adjunctive use for focal and generalized tonic-clonic seizures, can also work for some of the generalized seizures like absence and myoclonic seizures. It enhances GABA inhibition. And the side effects that we see with the GABA receptor agents are sleepiness, coordination problems, and memory problems. Psychosis is pretty rare. The other problem with the benzodiazepines is that they cause tolerance. So you've been taking a certain amount of drug and you get good seizure control, but then the seizures start to come back. You have to increase the amount of medicine. And so that makes them a little less useful. There's another form that we use that called clobazam that was approved for a specific syndrome, Lennox-Gastaut, but it turns out it's useful for a variety of other kinds of problems. It has a somewhat longer half-life. Both of these are fairly long half-life drugs, which is what makes them useful in epilepsy. One of the newer drugs we have, cannabidiol, tends to prolong that enormously, and so you have to watch that interaction. And Onfi or clobazam seems to be a little less subject to tolerance than some of the other benzo drugs. Phenobarbital, again, a sort of classic anticonvulsant, one of the first ones we had, is still out there, still being used. We still see patients on it. We don't use it very much, primarily because of this cognitive slowing that it causes. And interestingly, in kids, it's the opposite. It can cause hyperactivity. The way I tell people to understand that is if you inhibit the inhibition coming from the frontal lobe, then you get hyperactivity. So a negative on a negative is a positive. Tolerance develops to the sedation effect. It is a good anticonvulsant, but it just has this bad side effect profile that we try to avoid. A couple of other agents I'm cruising through. I'm trying to get done up to our sort of drug of the day. Ethosuximide is useful only against the absence seizures that I was mentioning before, where the bland staring spells, because it inhibits these T-type calcium channels. Zonisamide inhibits those as well, but also is a sodium channel drug. So it's useful for a variety of different types of seizure drugs. It has a long half-life, so we can give it only once a day. Ethosuximide is usually dosed once to twice a day. And so we have some newer drugs that we use that are also sodium channel agents, like lacosamide or Vimpat for partial seizures. Rufinamide, very similar kind of thing, was again approved like Onfi for Lennox-Gastaut syndrome, but it can be used for other things as well. One of the newer ones that we have in the last 2 years or so is cannabidiol. This is from the marijuana plant, from cannabis sativa. It is actually a plant product. They purify a specific strain of cannabis, It has no psychogenic properties, and it's delivered in an oil. And it does cause some decreased appetite and sleepiness, but it is actually pretty effective. It was approved again for Lennox-Gastaut and another childhood epilepsy syndrome called Dravet. We don't really fully understand how it works. It does not work at the same receptors as the tetrahydrocannabinol that is the agent that causes you to get high when you smoke marijuana. And then I'll finish up with one of the newest drugs that was just approved 1 year ago and is just now hitting the markets, called cenobamate. This drug has the fancy and unusual name of Xcopri. And so this drug has a variety of different mechanisms. It seems to enhance sodium channel inactivation, which is, again, one of our standard mechanisms. And it inhibits persistent sodium current, and that's a newer mechanism. It also seems to have an effect on the GABA receptor. It has a long half-life and is broken down in the liver. So it's once-a-day dosing, which is very helpful. Though one of the fancy and nice things about this drug is in the trials that were performed to get it approved, about 21% of patients who took it became seizure-free on this medicine. And that's really unheard of. Most of the trials, the drugs that we study in clinical trials, maybe a few, 1%, 2% will get seizure-free. This suggests that this is going to be a very effective drug. The adverse effects are pretty much the usual suspects for a sodium channel drug: coordination problems, dizziness, sleepiness, double vision. A couple of more unusual things: it can lower the potassium level, and it can cause a heart conduction problem called shortened QT syndrome. Again, rarely is that going to be problematic. It's structurally derived from this drug felbamate that came out in the early 90s that was very effective, but because of its specific structure, it seemed to have some toxicity in the liver and blood cells. That seemed to be very specific to felbamate, and the newer derivatives of this drug, like Xcopri or cenobamate, do not seem to have these problems at all. Just a quick word about seizure medicines in women. There seems to be an increased risk of polycystic ovary disease, particularly with medicines like Depakote. Infertility is more common in women who are taking seizure medicines. And seizure medicines, many of them can also impair calcium metabolism. And so we will often add vitamin D supplementation when we start people on seizure medicines. In pregnancy, we want to avoid certain medicines that are somewhat worse. There's a slightly increased risk with all of the seizure medicines, to about 5 to 6% risk of having a fetal malformation. That's over the general population, which is in the 2 to 3% range. So it's not a huge increase. At the bottom, the take-home message is that most women who have pregnancies have normal kids when they're on anticonvulsant drugs. The biggest danger is this overreaction, this tendency for patients to worry that suddenly they need to stop all their medicines. We definitely don't want to do that, because the risk of having a seizure is much more dangerous to the woman and the baby to be than staying on the stable dose of a seizure medicine. Again, we like to use folic acid to prevent neural tube defects. So when do we start a seizure medicine? It really depends on what we think the risk of a second seizure is. And for most patients that have a single seizure, we will not start on a seizure medicine. And only about a third of those will have a second seizure within 5 years. Treating with seizure medicines does not seem to decrease that long-term risk of recurrence. It does control it a little bit in the short term. So in general, there's no need to start an anticonvulsant for a first seizure when we don't know what that recurrence risk is. But if there are telltale signs that it's going to be higher than expected, like we find a structural problem on the MRI, or the EEG shows spiky discharges that suggest seizures are going to happen, then we may want to start it sooner. When do we take them away? Well, it kind of depends on how well they've performed. So for most patients, if they've been seizure-free for more than 3 years, they're on a single drug, their EEG and MRI are normal, then they have a good chance of being seizure-free off of medicines as well, unless they have one of these problems like juvenile myoclonic epilepsy that is something they were born with. This tendency to have seizures is not going away, and those people need lifelong treatment. So I will stop there. I went a bit long, but we started late. So both Dr. Martz and I are available for questions if there are any in our crowd.
Okay. All right. Did you give me control back, Dr.
Let me do
Greenfield?
that.
Okay.
Let me do that. Give up remote control. Okay, you got it.
Thank you. And I think we did really well on time considering our technical difficulties there at the beginning. Thank you so much to both of you for presenting. And I actually do have a question. I believe Dr. Martz mentioned something briefly in his presentation, but it really is incredible all the different formulas that are available to people that have seizures. What would be a way to explain for those that their seizures are just not controlled on even several medications?
Uh-oh. You may be stuck and muted. Uh-oh. Okay, so I'm going to rescue Dr. Martz since I'm not muted. So there's a variety of things you can do if the patient's gone through several medicines and not responded. There are things like the ketogenic diet, which we do more in kids than adults, where there's a high proportion of fat relative to carbohydrate. That's one thing that can help. But increasingly, if you've failed 2 or more drugs that are appropriately chosen at good therapeutic doses, it's time to start thinking about whether you're a candidate for epilepsy surgery. And that's a big, long, complicated process, but it is one of the few things that can really produce seizure freedom. And so if we've tried many drugs and not been effective, that's usually the next thing to think about.
Thank you, Monica. You helped me to unmute. I echo everything that Dr. Greenfield just said. I would only add that, I mean, I guess beyond really your question, but the issues of refractory epilepsy, refractory meaning does not respond fully to medications, are not only seizures. People with refractory epilepsy as a large group are less likely to complete college, less likely to get married, less likely to be able to drive, more likely to be depressed. So there's a number of other problems that come along with it. And I think, as people who see a lot of folks with epilepsy, we are focused on all of it, trying to get quality of life better. So in addition to stopping seizures, sometimes it's making life more livable with seizures. We certainly focus on stopping seizures with every possible treatment, but sometimes that's not the best thing for a patient in that part of their life. Maybe they need to get through school, and then after school they can think about the surgical evaluation. So there's any number of ways that we can help based on the patient's goals and the timing of those goals. And we certainly can offer all the above at this time.
Thank you. And we do have one more question here. Do patients often need more than one surgery, or how frequent or infrequent, I guess, does that happen where you'd have to perform multiple surgeries? And I know we're talking about medications here, but I know surgery is certainly an option too. So
we were just discussing this in our surgical conference. So just to give a sense of how these decisions are made, first of all, from a surgery standpoint, we have what we call a refractory epilepsy committee, which is a committee made of all of our epileptologists. We have 10. There are neurosurgeons who are specialized in epilepsy. We have 2. There are neuroradiologists who look at all the MRIs and other types of imaging that we have that go into the surgical workup. neuropsychologists who evaluate the ways that seizures and epilepsy may be impacting someone's ability to think in terms of math and map making and all the other types of thinking that we do, as well as the impact a surgery might have on those things. We have a social worker, we have a psychiatrist, there's a whole number of team members, and we all review a case in depth and discuss what might be the best treatment for that person. And sometimes we think a surgery is the best treatment, and sometimes we don't. When it is a surgical recommendation, it's a great question you've asked, because there used to be really, we can try to cut that part out or not. So classically, we think about surgery really with two main questions. One is, can we find the spot causing seizures? And sometimes there's multiple spots, or sometimes it's very hard to find. Number one, can we find it? And number two, could we damage it or remove it in a way to try to cure the seizures from not happening anymore? Or would it be too dangerous? Is it unsafe? In other words, if we found the spot, but it's right where your language centers are and you wouldn't talk again, we would never recommend doing any surgery there. So it's those two main questions. And what's happened over the last 4 or 5 years, more so than even before then, is surgeries have evolved. We only had sort of one option, mainly was to take out the part of the brain that was causing seizures. Or there was a non-brain surgery for vagus nerve stimulation that could be effective for some patients as well, kind of like a pacemaker for the brain. Now we have other types of stimulators. We have other types of less invasive surgeries that we can do that focus on only a very small area of brain being injured in a day surgery, essentially, as opposed to a multi-day stay for a classic resection surgery. So as we move towards these variety of options, the types of patients who become candidates for surgery increases a lot. And sometimes where we would have a hypothesis and say, we think it's either here or here, we couldn't do surgery before. But now there's the option to say, well, we think it's here or here, and we can do a very non-invasive procedure here on this one spot, and we'll see how that goes. And then if that doesn't work for you, we think the risk is very low. But if it doesn't work for you, we have a backup option of this other spot we can look into. So more and more we are seeing what people call staged surgeries, or a series of planned surgeries or possible surgeries. I think that for some people that might sound horrible, and that wouldn't be a good option. For other people, I think it's really the right thing. And some of them do come through a series of procedures like that, and in the end are much, much better, where medicines really offered no chance of seizure freedom and improved quality of life. Going through the difficult but necessary process of surgeries really did help them. So it's a great question, and it's actually an evolving answer. We're in the middle of a change in our paradigm of how we think about surgery across the country right now, and that question is perfectly timed.
And is it common for people to have more than one surgery? Like if they have brain surgery and then will be in need of another surgery?
Well, we're talking about surgery. I think we're referring to a treatment surgery where you try to stop the seizures in epilepsy. And in that case, it's becoming more common. The other factor here is that some people require a surgery as part of the diagnostic process, what we call intracranial EEG, where we would do a surgery to place the electrodes in or on the brain. We do that when we have a good sense of where the seizures are coming from, but not a perfect sense. And we want to localize with pinpoint accuracy where exactly our seizures coming from. And that is a surgery. And then after that surgery, people stay in the hospital and do seizure monitoring for typically a week or so, maybe 2 weeks. And we try to identify exactly where the seizures start and also determine safety. We use that procedure for safety evaluations as well, in terms of could we do a surgery in certain brain areas in a safe manner. So that is a surgery that often precedes a treatment surgery. So if someone has a resection or even a laser ablation or an implanted stimulator device, very often they will have had an intracranial EEG diagnostic surgery before that. So in that sense, having at least 2 surgeries is very common these days. It's becoming more and more common. Would someone have 2 treatment surgeries? We usually try to not need that. We try to solve the problem if we can in the first
Yeah.
surgery. But even that, more often now we're seeing 2 treatment surgeries or more. The surgeries are very safe, actually. It's a sort of misconception. It is brain surgery, but the safety of these surgeries is assured by the pre-work that goes into it, months of work ahead of time to plan to make sure it's safe. And then the surgeon's skill is the other factor. And we, of course, have surgeons who are very well trained and have done epilepsy specialty training and do a lot of surgeries. So we feel that it's very safe. So in that sense, doing multiple surgeries doesn't necessarily increase the risk of the surgery significantly, but it does potentially increase the benefit if it took a few staged surgeries to get to the end result of seizures being stopped.
Well, thank you, both Dr. Martz and Dr. Greenfield, for all of this information. And we would like to also thank SK Life Science for encouraging this presentation today. I think it's a very appropriate one to have every now and again, just to kind of give people updated information. And it certainly is explained in a way, I think, that probably most people have not really heard before. So it was really great. And I want to let everyone know that we're going to be hopefully editing this to kind of cut out that first part where we were having technical problems. And this will be available on our website at epilepsyct.com. And we'll also go ahead and post this on our Facebook page as well once we edit it. Again, thank you all for sticking with us during that time. It was great. And hope you all have a good evening. Please, let us know if in future, if there are other topics that you would like us to sort of present on or have doctors in the community present on. Okay, well, thank you all. Have a good evening.
Thank you very much.
Thanks, Monica. Thanks, Meredith.
Appreciate you guys getting this together. And Dr. Greenfield, wonderful to work with you.
Thanks, Gabe. Take care.